Good evening. I'm psychiatrist Jay Fawver, live from the Bruce Haynes studio in Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 27th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, call me in the Fort Wayne area by dialing 969-2720, or if you're calling any place coast to coast, you may dial toll-free at 866-969-2720. Now, on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at mattersofthemind, all one word, at wfwa.org. That's mattersofthemind at wfwa.org. And I'll start tonight's program with a question I recently received. It reads, Dear Dr. Fawver, my job is super stressful. So when I come home, I need 10 minutes of quiet before engaging with my family. Is there a better way to deal with stress so I can feel more present at home? Well, that's a great start. At least you're giving yourself 10 minutes to be more present with your family, because when you come home, it's very difficult to do, but it's exceptionally important to shut off all messages from work, to try to allow yourself to process what happened at work and then be done with it. So what do people do? If you have a little bit of a bridge between work and home, that often helps. And that bridge can be something as simple as going to the gym, working out for 30 minutes, going for a walk for 20 minutes. Sometimes that's a way of kind of winding down before you go home. But I think what you're doing already is fantastic. You're allowing yourself 10 minutes to kind of chill out and then have that bridge to be able to engage with the family. It's so important to do because many people will keep their email up at night. They're still texting their coworkers at night. They're still working through problems at night, and that's not healthy for the family, obviously. I had to learn this when I was in psychiatric residency, because when I would go home, I would often keep patient care on my mind. I'd ruminate about decisions that I'd made throughout the day, and it was very difficult to become more engaged with the family because you're still thinking about things. You have to find that bridge to allow you to get home, and for me, sometimes it was watching a 30-minute sitcom with my family as soon as I got home, and that was sometimes the bridge just to get me to disengage from work. So use that bridge like you're doing. 10 minutes is great. If you need 30 or even 40 minutes, that's even better for a lot of people. Thanks for your email. Let's go to our first caller. Hello, James. Welcome to Matters of the Mind. James, you want to know what's the difference between bipolar 1 disorder and bipolar 2 disorder. Well, it's a subtle but important difference, James, and I'm going to make a comparison here. Bipolar disorder is a mood disturbance where people can have highs and lows in their mood. And it's a subtle distinction because you're going to treat them differently. So bipolar 1 is treated differently than bipolar 2 disorder, not unlike headaches. If you have a headache, you want to know, is it a tension headache, a cluster headache, a migraine headache, a sinus headache? What kind of headache is it? Because those 4 different types of headaches, even though they're all headaches, will be treated entirely differently. The same with bipolar disorder. Bipolar 1 disorder is where somebody has experienced a manic high. And that means for at least 7 days or at least 7 days, they've experienced racing thoughts. They talk really fast. They are doing things impulsively. They don't need to sleep. They are saying things and doing things they ordinarily wouldn't say or do. They're butting in on conversations, and they can be very annoying to other people. Bipolar 1 patients often and frequently will crash into lows, but not always. Some of the people who are very difficult to treat only have manic highs, then they come down to a normal mood. People who only have manic highs and going into a normal mood often don't find themselves really having a problem. Other people do, but they don't. Many people will present to us, clinicians, when they're experiencing depressive episodes. So for somebody with bipolar 1 disorder, more often than not, won't come to see us when they're having a manic episode. They come to see us when they're having these depressive episodes because they've been to the mountaintop and now they're crashing in their mood, and often they're suicidally depressed. So it can be very devastating for a lot of people. Bipolar 2 disorder is where people will have little highs that aren't as functionally impairing. With a mania going on for at least 7 days, typically that'll be functionally impairing. A hypomanic episode will occur between 4 and 6 days. It's not highly functionally impairing during those days, but people will crash into lows for at least 2 weeks. So with bipolar 2 disorder, by definition, you have little highs that aren't highly problematic, but then you go into these really deep lows for 2 weeks. For those people, we're going to certainly treat them with mood stabilizing medication, and we will often use an antidepressant to help them. With bipolar 1 disorder, we're going to mainly use a mood stabilizing medication and be very, very, very cautious in using any antidepressant medication, because if you use an antidepressant medication when somebody has a bipolar 1 disorder, you need to make sure they're not going to go into highs, because you can trigger that high with an antidepressant, so we have to be careful about that. Bipolar 1 disorder, more common with bipolar disorder, it's pretty much equal for men and women. Bipolar disorder type 2 is more common with women compared to men. And with bipolar disorder type 2, you're going to hear about the comorbidity of migraine headaches, especially for women. So women who have bipolar 2 disorder will be more prone to having migraine headaches. So often for those women, we'll give them a mood stabilizer that also will address the migraine headaches, like lamotrigine, also known as Lamictal, Trileptal, also known as oxcarbazepine, gabapentin, also known as Neurontin. So we'll use some kind of medication that's going to address the moodiness associated with bipolar 2 disorder, but also addresses the migraine headaches. Thanks for your call. Let's go to the next caller. Hello, Diane. Welcome to Matters of the Mind. Diane, you want to know, is there an effective cholesterol medication that does not cross the blood-brain barrier and rob the brain of essential fat? Yeah, there are some medications that will be more prone to crossing the blood-brain barrier. I think you need to work that out with your clinician. You know, there's a medication that can lower cholesterol by the name of Welchol that doesn't really have an effect on the blood-brain barrier. It's affecting absorption more often than not. There are some of the statin medications, some of which don't cross into the blood-brain barrier as much as other. Atorvastatin, also known as Lipitor, has very little crossing into the blood-brain barrier. So it's the type of thing you talk over with your primary care clinician. The key, Diane, will be if you take a statin medication and you all of a sudden notice you're more depressed and you have difficulty with thinking and concentration, if it started when you started that medication, you might want to go back to your primary care clinician, your cardiologist, whoever might be prescribing it, and say, I felt like this, this, and this after I started that medication. So even though you might take certain medications that do cross the blood-brain barrier and can affect the lipid constituency in the brain, they might not give you those problems. But there are some medications, like I said, atorvastatin, Lipitor is one medication that doesn't cross the blood-brain barrier so much and is less associated with those difficulties, such as the cognitive impairment and the depression and the fatigue. So the key will be, upon starting any medication for cholesterol, observe how you're doing thereafter and go from there. Diane, thanks for your call. Let's go to the next caller. Hello, Timothy. Welcome to Matters of the Mind. Timothy, you want to know why in commercials with medication are there so many potential side effects? That's because the Food and Drug Administration will force the pharmaceutical companies to put all those side effects on there because they potentially can occur. So you can have a commercial with a smiling person and everybody looks happy and they look like they're enjoying their medication, and then you have this scrolling side effect profile on there. So the government perceived that if you're going to see a commercial concerning a medication, you have to know of all the possible side effects. The key about those side effects, however, will be that people will often not experience them. They're possible side effects. Side effects of any medications, number one, are often related to the dosage. The higher the dosage, the more likely you have side effects. And they many times are time related. You'll have more side effects early on when you initiate a medication, and those side effects often subside thereafter. So you have to keep the side effects in perspective. Those side effects do not occur for everybody. If you have a side effect occurring with 1 out of 20 people typically, that side effect will be listed in those kind of commercials. So when you see the small print, the fast rate of speech of somebody talking on the commercial about the different side effects, often they're conveying the side effects that can occur with over 5% of the people. So you might have 1 out of 10, even 1 out of 20 people having a side effect, but the rest of the people don't have that side effect. Well, that's going to be reported on the commercials themselves. So it's the type of thing where I always wondered why a pharmaceutical company would want to have these so-called direct-to-consumer ads direct-to-consumer ads is where you're actually advertising to the general public. I think what they want to do is get the name of their medication on the mind of the patients who might have these particular conditions, such that when the clinician refers to these medications as a possible option, the patient has the name recognition already. It's kind of like a politician having the political ads out there, just getting the name recognition. So I think the pharmaceutical companies want to have the name recognition, but from my perspective, I always wondered the strategy behind that. And there must be some reason for it, kind of like with negative ads with politicians. People say, why do there have to be so many negative ads? Well, the negative ads sell. So the reason politicians use negative ads is because people will be more inclined to hear negative material, whether it's on the news. They always talk about horrible stories on the news. Those are the ones that get people to watch. But our brains will get more engaged when we hear about bad things happening, whether it be on the news, whether it be in political ads. From my perspective, that might include direct-to-consumer drug ads with the pharmaceutical companies. So when people are watching those ads, I would think they are going to be more prone to hearing about all the side effects from the medications that, quite frankly, might not occur that often. But I'll ask people when I'm prescribing a medication, have you heard of this medication? And not only am I asking, have you heard about it on commercials, but have you heard about it from other family members? Have you heard about it because you might have taken it in the past? Have you heard about it from friends or any social acquaintances? Because when people hear about medications, they might have good or bad perspectives on those medications. So I want to know what's their preconceived notion about the medication before I consider prescribing it for them. Thanks for your call. Let's go to our next caller. Hello, Derek. Welcome to Matters of the Mind.
Doctor, how you doing today?
Hey, Derek, I'm doing okay.
I was just wondering, I was building an ethanol plant in southern Indiana, and my brother and I slept in this apartment. Next to it was a huge electrical room, and we'd wake up at work and felt like we had a little brain twitch. We didn't actually know if it was the electrical equipment or not, because we started taking fish oil, and that, brain twitch went away. I'm going to hang up, but just tell me a little bit about what you think about fish oil. Thanks a lot, brother.
Hey, Derek, thanks for calling in. The electrical effect on you externally, I don't know. It's hard to say. I'm always prone to say what I thought 20 years ago might be different than what I think now. So even though I don't know a lot about the influence of external electrical activity affecting your brain now, ask me in 20 years, God willing, if I'm still around, and I might have a different perspective. But right now, I don't really know about the effect of external electrical activity on a person's brain. Fish oil, you bet. Fish oil has the omega-3 fatty acids in it. There's omega-3 fatty acids and there's omega-6 fatty acids. You want predominantly the omega-3 fatty acids. You get an adequate amount in fish oil typically. Various amounts can be used. Fish oil has been mostly studied on the good cardiovascular effects. Good effects on the heart. So fish oil can decrease triglyceride levels. So that's those are the types of lipids, the types of fats that will go up, especially with a high carbohydrate diet. So fish oil can modulate that somewhat. Fish oil typically will be very well tolerated. If you get too much, sometimes it'll give you some gastrointestinal effects or diarrhea, but it's very well tolerated. But fish oil potentially can be effective for the brain. There was a study a long time ago just observing that women in Japan had less postpartum depression compared to women in various other parts of the country. And it was thought it was because they had more exposure to consumption of fish in Japan. So they were thinking that maybe fish oil should be regularly prescribed for people with depression. And that was commonly done about, 20 years ago. 20 years ago, people would take fish oil supplements very commonly. Not so popular now, but I think if you have high cholesterol, especially high triglycerides, and you have difficulty with depression and concentration and memory, sure, fish oil could be beneficial for you as long as you don't have any of the gastrointestinal side effects. It appears to be very safe to take for a lot of people, but especially the omega-3 aspect of it. Omega-3 has a very strong anti-inflammatory effect compared to omega-6, so the omega-3 aspect of the fish oil can be helpful. Thanks for your call. Let's go to the next caller. Hello, Anthony. Welcome to Matters of the Mind. Well, let's go to Well, let's see. Do we have Anthony on the line? Well, Anthony, you had a question about gabapentin. Gabapentin is a medication that's been around since the 1990s, and gabapentin is a medication also known as Neurontin. And your question was, what does gabapentin do? Basically, gabapentin will modulate this particular chemical called GABA. GABA acts as the brakes on the brain, and acting on the brakes on the brain, gabapentin was originally studied for seizures, and it was studied and approved for seizures back in the 1990s. And then we in psychiatry started using it for anxiety. We started using it for pain. We started using it for sleep, and we found that it had a lot of good different uses. Gabapentin has less effect on the memory and concentration compared to benzodiazepine medications for anxiety, such as Xanax, Klonopin, Valium, Ativan. These are medications that are going to affect your concentration and memory, and they can also make you more depressed because they can kind of zap you of your motivation. Gabapentin is less prone to doing that at lower doses. Now, gabapentin has its drawbacks. If you use gabapentin, especially with a pain medication like an opiate, it can amplify the effect of the opiate and sometimes give you excessive sedation and give you a lot of side effects from the opiates. So if you're not on an opiate, it can be typically used. With an opiate, just be aware that it's going to be more amplified in its effects for the pain itself. So it's something that we're using more extensively in the state of Indiana right now, Neurontin or gabapentin. It's monitored, but it's not a controlled medication. It's controlled as it's a controlled medication in Ohio and Michigan, states around us, but not in Indiana. But it is a medication that we watch for any potential abuse. If somebody's using more gabapentin than they ought to be using, we are always on the lookout for that. But they did a study in New Jersey 20 years ago looking at patients who were taking gabapentin and found that only about 3% of them got in trouble with it where they abused it. So yeah, you can get a high on it if you take too much of it or excessive amounts, but most people don't do that. Thanks for your call. Let's go to our next caller. Hello, Anthony. Welcome to Mayor's the Mind. Anthony, you want to know, is irritability a side effect of glipizide? Glipizide is one of the GLP-1 agonists that are very popular now. Glipizide is a medication that has been around. It's used for type 2 diabetes. It's also used for weight loss. And is irritability a common side effect from it? I wouldn't say it's a common side effect as it would be from any of the GLP-1 agonists, Anthony. It's something that can decrease. It can decrease your appetite if you have maybe collateral symptoms around it. I'd take a look at your other medications you might be taking. But keep in mind, Anthony, as I tell people many, many times, if a particular adverse event occurred directly associated with your taking a particular medication, it's probably related to the medication itself that you're taking or the consequences of the medication. So if you're getting more irritable, perhaps due to blood sugar changes, sometimes people will drop their blood sugars as they can from glipizide. If you're dropping your blood sugars, and in doing so, that's causing you to have irritability, that can sometimes be an effect. But it's something you can discuss with your clinician, especially if the side effects occurred shortly after experiencing the medication itself. Thanks for your call. Let's go to our next caller. Hello, Karen. Welcome to Mayor's the Mind. Karen, you want to know, is it possible to get psychosis from scrolling the internet? I think what I hear about from scrolling the internet, Karen, will be more commonly people describing trouble with what I call a social contagion. In other words, they have a lot of people talking about particular issues and they kind of jump on board with it. And there's a couple things happening in the brain there. On one hand, as the brain opened up here, the front part of the brain's looking at you. On the inside part of the brain is this part of the brain called the ventral medial prefrontal cortex, which gives you your identity. It allows you to know who you are and what your values are, what your morals are. It gives you a sense of identity yourself, and it's the ventral medial prefrontal cortex. Then just above that is the dorsal medial prefrontal cortex, where your values are trying to align with people around you to fit into the herd, to fit into the group itself. So you've got the social aspect of it aligned side by side with your own personal identity. When you're scrolling through the internet and you're getting these ideas from other people, you can have kind of what I just refer to as a social contagion, where a particular idea becomes popular. And as it becomes popular, some people can say it gets them to thinking about things they ordinarily wouldn't believe, and they start to wonder if they're losing their identity. Well, that can happen from scrolling the internet and seeing particular ideas or values or perspectives that might be different from your own. If you see it again and again and again, it can alter your beliefs. Now, many people will hang on to their beliefs, and that's what the ventral medial prefrontal cortex does on the inside there. It'll allow you to have ingrained beliefs, and sometimes people need to shake that loose to be able to believe otherwise. But I think it's very important for you to always try to be objective. Just because you're having 10 or 20 or hundreds of people on social media aligning to a particular thought doesn't mean that you have to wholeheartedly assume that kind of belief. And I think for some people that can come across kind of as a psychosis. A psychosis, by definition, is where your reality is distorted. Now, if you're already prone to having a reality that's distorted, yeah, social media is often not going to be healthy for somebody, but a psychosis is where you can have fixed false beliefs, where the beliefs are fixed, they're very tightly ingrained, they are beliefs that in which you cannot be, you will not find to be able to be disputed. They're false because they have no meaningful reality behind them. So a psychosis includes delusion. Sometimes you can have perceptual disturbances with a psychosis where you see things, hear things that aren't there, and other people can validate that. So a psychosis is a little bit different from a social contagion, but a social contagion will be a belief that's socially popular, but it's a belief, and it usually will fade away over the course of several years. And it's something that we'll hear that's popular now, but years from now it won't be. We've heard about beliefs from the 60s, the 70s, the 80s that are no longer firmly held beliefs anymore because they were social contagions back then. We have some of those now. Thanks for your call. Let's go to our next email question. Our next email question reads, Dear Dr. Fawver, is it important to be in psychotherapy while taking medication? You know, with a newer medication we now are using, it's interesting how we're using them because they're working very fast. The ones that affect glutamate will allow the branching and the root system of our individual neurons to grow within a matter of hours after taking these medications. So in your brain itself, you have about 80 billion different neurons, and each individual neuron has between 20,000 and 50,000 branches. Like in the hippocampus here, the memory center, that has about 50,000 branches per neuron. When you have chronic depression or chronic unmitigated stress where you're just overwhelmed by things, the little neurons start to shrivel up. And it's like a bush in your backyard where above the ground, the branching is decreasing. And if you look below the ground, you know the root system is decreasing. Well, that's similar to the neurons where you have the dendrites and you have the axons. The axons themselves are decreasing in number, as are the dendrites, so it's like decreased branching. Well, if you give somebody a medication such as ketamine, Spravato, also known as esketamine, Auvelity, these are medications that we now have available for the treatment of depression that can rapidly, within a matter of hours after administration, increase the branching. So it's like having a bush that's above ground, increasing its growth with the different branches, and then you have the roots down below. If this is occurring, keep in mind you need to keep your brain busy and stay active, and that's where psychotherapy can come in. Not only do you just take the medication, but you need to be more active in engaging with people socially, exercising, doing all these different things that will help your wellness itself. So that's the purpose of psychotherapy while you're taking the medication, doing something with all that branching. And finally, let's take our last call here. Hello, Robert. Welcome to Matters of the Mind.
Well, nice to talk to you, Doc.
Hey, Robert. Good to hear from you.
Yeah. So you hold up your brain quite a bit and show where the amygdala is on the one side.
Yeah.
Is the amygdala on both sides? Is it on the right side and the left side?
It is. It's on both sides, Robert. Good observation. This is the thumb of the brain. The thumb is the temporal lobe, and you got a thumb on both sides. The thumb kind of looks like a the brain looks like a boxing glove, and the thumb is the part of the boxing glove here. That's the temporal lobe. Right in the front is the amygdala. Now, the amygdala on the left side for many people will have a greater influence because many of us are right-handed, but the right side amygdala can occur, certainly very active as well. So we do have an amygdala on both sides. Amygdala in Latin means almond shape. It's about the size of an almond. If you dissect somebody's brain and you find the amygdala, you'll find it to be about the size of an almond. The amygdala is indeed responsible for fear, anger, anxiety. It's responsible for rage. It's basically our emotional volume control. And if the amygdala gets too hot and it gets overactive, it can hijack the thinking part of the brain itself. That's why we're always talking about the amygdala and trying to get that calmed down. Robert, thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions that I can answer on the air, you may write me via the internet at Matters the Mind, all one word, at WFW&A. And I'd like to see if I can answer those on the air. I'm psychiatrist Jay Fawver, and you've been watching Matters the Mind on PBS Fort Wayne. God willing and PBS willing, I'll be back again next week. Thanks for watching. Good night.
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronHealth.com.